Hello everyone, my name is Dr. Lauren Hagel and I am a former orthodontic resident at the University of Washington. I am currently practicing in the Seattle area. Today we're going to discuss a case that I treated in residency under the supervision of our program director, Dr. Anne-Marie Bollen. Upon initial presentation, my patient was 13 years and 3 months and was referred to our clinic by his pediatric dentist for evaluation for crowding and a missing tooth. The patient's chief concern was the position of his upper right canine, how to address his missing tooth, and that he played the flute, so he wanted to make sure orthodontics did not interfere with his ability to play his instrument. His medical history was non-contributory and denies any history of oral habits. His dental history is significant for an extraction of number 30, or the lower right 6, due to internal root resorption, and this occurred about 1 year prior to his presentation in our clinic. He had no other history of orthodontic treatment. Pre-treatment facial photographs reveal a convex profile, obtuse nasolabial angle, normal mentolabial fold, a longer lower facial height, and he is grossly symmetric. At rest, he displays no lip or mentalis strain, and on smiling, he shows 100% of his incisors, and his smile arc is consonant with the lower lip. Dentally, our patient is in the full permanent dentition and has good oral hygiene. He presents with a Class 2 Division 1 subdivision malocclusion with the Class 1 side on the left. The study casts reveal that he has an increased overjet of 5 millimeters and a 40% overbite. His maxillary midline is coincident with his facial midline, while his mandibular midline is 2 millimeters to the right of the facial and maxillary midline. He has a maxillary arch length deficiency of about 4 millimeters, mandibular anterior crowding of 3 millimeters, and 2 millimeters of spacing between the lower right 5 and lower right 7, due to the missing lower right 6. The lower right 7 had favorable eruption into the place of the right mandibular first molar, or the lower right 6. However, it is still significantly tipped mesially, as evident also in the panoramic radiograph. The pre-treatment radiograph shows normal condyles of good cortication, and besides number 30, he has a full complement of permanent dentition, including developing third molars in all 4 quadrants. A 1 by 2 millimeter ovoid radiopacity is evident over the distal portion of the upper right 2, or tooth number 7, just apical to the crest of the alveolar bone. After CBCT, it was deemed a supernumerary tooth and was extracted prior to the beginning of orthodontic treatment. Otherwise, there was no evidence of caries or growth pathology. The lateral cephalometric analysis indicates an orthognathic maxilla and mandible. However, due to a slightly higher than normal SNA and slightly lower than normal SNB, there was an increased A and B, which indicates a skeletal discrepancy. His mandibular plane angle is increased, indicating a hyperdivergent skeletal growth pattern, and he also has a retrusive chin button. Dentally, both his maxillary and mandibular incisors are well positioned. 2 treatment alternatives were presented to the patient and his family, these being opening space to replace the missing molar or closing the space and substituting the lower right second molar into the space for the lower right first molar. The modality for Class 2 correction, as well as using fixed appliances or clear aligners to achieve our treatment goals, were also discussed with the family. If you're interested in how this case was treated, please go to the Spring 2023 PCSO Bulletin. Thank you.